I'm Dr. Robert Kaufman, and it's time for us to go beyond the terminus. Today, we're going to talk about emergency treatment in the case of pulpitis. Acute pain situations can be difficult to manage, but not necessarily from the treatment standpoint. That's usually pretty easy. Endodontists are faced with the question, is treatment and rehabilitation of this particular tooth in the acutely involved patient in the best interests of the patient? And who decides that? In the case of deep decay, subgingival caries under margins, or teeth with questionable periodontal status, overall assessment of the tooth needs to be done before the tooth is sent for referral. There's no point in having an endodontist perform an emergency treatment only to find that the tooth is not restorable, is periodontally compromised, or that the patient never really intended to have the tooth restored properly in the first place. So is the tooth restorable? That's not something that should be assessed by the endodontist. It's your patient, and that's something you need to confirm. I have referrals such as prosthodontists with aging patients who have no hesitation attempting to patch extensive fixed prosthetics simply to try to keep and maintain the existing restorations. In these very elderly or medically compromised patients, we acknowledge the patient's limitations and are strictly trying to make the restorations last for the remaining years the patient is alive. However, in most routine cases, it is the referring dentist that needs to decide whether and what will be left after the endo is worth the effort to treat it. Patients also need to know if adjunctive treatment such as crown lengthening is necessary to allow them to maintain the reconstructed tooth. Devitalizing a tooth and then restoring it with the same initial problems is a recipe for treatment failure. So, what do you do when you've diagnosed endodontic involvement in the patient who is acutely involved? The most obvious question is, how badly does the patient wish to keep the tooth? There may be situations where there's no concrete treatment plan, where there may be other priorities or finances may not allow for the definitive treatment and restoration right away. We simply want to get the patient comfortable while we decide whether rehabilitation of the tooth is part of the overall treatment plan. The first thing you need to do to determine is the extent of the pulpal involvement. And that means we have to use very specific terms to describe the patient's condition. It is this specificity that helps us discuss the clinical situation and guide us as to how to most efficiently deal with the current complaint. We need to define the difference between reversible and irreversible pulpitis. Both are managed differently in acute situations. We also need to establish whether there is any periapical involvement of the tooth, generally indicated by percussive sensitivity or apical swelling. The terms abscess and infection are thrown around all the time, and they're often misused by clinicians when discussing patients' problems with them. When it comes to clinical decision-making, these terms are not only wrong, they can lead to misdiagnosis and especially improper medication with things like antibiotics that are absolutely unnecessary. Our first emergency patient has thermal sensitivity, mainly to cold. It's brief or momentary, but it is acute. There may be a history of recent restoration, but the symptoms appear to be improving with time. So what do? Well, we examine the tooth clinically. We check for fractured restorations, open margins, or other obvious problems. Radiographically, we attempt to determine the extent and the depth of the restoration. Periapical radiographic findings and bite wings and posterior teeth especially appear to be within the normal limits. We then run our thermal tests to confirm that no abnormal response to heat is present, which would indicate irreversible pulpitis. Confirm the tooth that you are dealing with cold. It's surprising how patients can sometimes insist that it's one tooth, and when we do our test, we always find the current complaint is from another source. Always reproduce the patient's symptoms in the chair yourself. Do not rely upon the patient to tell you which tooth it is, or the notes from another clinician. Pulp status can change overnight, and you must confirm the symptoms at the time of your examination in order to arrive at a proper diagnosis. In this case, we probably have likely reversible pulpitis. What if the symptoms are improving with time? Well, first thing we do is we check the occlusion, and we also check for the presence of recession that may have been caused by placement of a rubber dam clamp or perhaps some sort of gingival procedure that has exposed the root. We discuss treatment versus no treatment options with the patient. Some patients are more tolerant of thermal sensitivity than other patients. In certain situations, such as when the patient is going away for long periods of time, or if they're traveling to places that may not have sophisticated dental treatment available, they may choose to electively treat the case now rather than wait until symptoms are worse. In the second part of the series, we're going to discuss patients whose symptoms to thermal sensitivity are not improving and how to treat them. Thanks for joining me, and I welcome you on our next trip when we go beyond the terminus.